السلام عليكم. صف خامس. محاضرتنا اليوم راح تكون عن ال intraocular tumors. راح نناقش بيها the most important intraocular tumors اللي هي retinoblastoma and malignant melanoma. We will start with retinoblastoma. Retinoblastoma is the most common primary intraocular malignancy of childhood and accounts for about 3% of all childhood cancers. Even so, it is rare, occurring in about 1 to 17,000 live births. Patterns of a tumor separate. A. Growth pattern may be endophytic. That means into the vitreous, with seeding of a tumor cells throughout the eye, or exophytic, into the subretinal space, causing retinal detachment. B. Optic nerve invasion, with separate of a tumor along the subarachnoid space to the brain. C. Diffuse infiltration of the retina, without exophytic or endophytic growth. D. Metastatic separate to regional lymph nodes, bone, lung, and brain. The genetics of retinoblastoma. Retinoblastoma results from malignant transformation of a primitive retinal cells before final differentiation. Because these cells disappear within the first few years of life, the tumor is seldomly seen after 3 years of age. Retinoblastoma may be heritable or non-heritable. The heritable or the germline retinoblastoma accounts for 40%. An association with advanced paternal age suggests that in some patients the mutation has occurred in the father's sperm. Because all the retinal precursor cells contain the initial mutation, these children develop bilateral and multifocal tumors. Heritable retinoblastoma patients also have a predisposition to non-ocular cancers, most notably by pineal or supracillar primitive neuroectodermal tumor, also known as pinealoblastoma, and trilateral retinoblastoma, which occur in about 3%. Second, malignant neoplasm include osteosarcoma, melanoma, and malignancies of the brain and lung. Each of these tumors tending to occur in a particular age group. The risk of the second malignancy is about 6%, but this increases fivefold if external beam radiation has been used to treat the original tumor. The second tumor tending to arise within the irradiated field. The second type is non-heritable or somatic retinoblastoma, accounts for 60% of cases. The tumor is unilateral, not transmissible, and does not predispose the patient to second non-ocular cancers. The patient usually has a solitary retinoblastoma and no positive family history. The presentation of retinoblastoma. Presentation is within the first year of life in bilateral cases and around 2 years of age if the tumor is unilateral. First, leukochorea, which means white pupillary reflex as you've seen in these photos, is the commonest presentation, represent about 60% of presenting cases, and may first be noticed in family photographs. Strabismus is the second most common presentation, about 20%. Fundus examination is therefore mandatory in all cases of childhood strabismus. Other type of presentation is secondary glaucoma, which is occasionally associated with ophthalmos. Diffuse retinoblastoma, invading the anterior segment, tends to present in older children. It may cause a red eye due to a tumor-induced uveitis and iris nodules, which may be associated with pseudohypopyon. Orbital inflammation, mimicking orbital or preseptal cellulitis, may occur with a necrotic tumor. It does not necessarily imply extraocular extension, and the exact mechanism is not known. Other type of presentation is orbital invasion with a proptosis and bony involvement, may occur in neglected cases, as you've seen in this photo. Other type of presentation, we have the metastatic disease involving the regional lymph node and the brain before the detection of ocular involvement is rare. Also, raised intracranial pressure due to trilateral retinoblastoma before the diagnosis of ocular involvement is also very rare. Sometimes, during the routine examination of patients to be at risk, we will find retinoblastoma accidentally. The signs that we see during examination. Indirect ophthalmoscopy with scleral indentation must be performed on both eyes after full mydriasis. This is because without eye indentation, pre-equatorial tumors may be missed and one eye may harbor multiple tumors. The clinical signs depend on the tumor size and growth pattern. We have intraretinal tumor, endophytic tumor, and exophytic tumor. An intraretinal tumor is a homogeneous, dome-shaped white lesion which becomes irregular, often with white flakes of calcification. The endophytic tumor projects into the vitreous as a white mass that may seed into the vitreous. An exophytic tumor forms subretinal, multilobular white masses and causes overlying retinal detachment. The investigations. Number 1. Red reflex testing with indirect ophthalmoscope has been recommended as a screening test in the community. Any asymmetry indicate full eye examination with a pupil dilatation and immediate referral to an ophthalmologist. Second, examination under anesthesia, including the following: general examination for congenital abnormalities of the face and the hand, tonometry, that means measuring of intraocular pressure, measurement of corneal diameter, and if glaucoma presents the axial length of the eye, anterior chamber examination with a hand-held slit lamp, also ophthalmoscopy, documenting all findings with color drawing or photograph. 3. Ultrasound is used mainly to assess tumor size. It also detects calcification within the tumor. We will continue with the investigation. 4. CT scan also detects calcification, but entails a significant dose of radiation and is performed only rarely. 5. MRI cannot detect calcification, but it is superior to CT for optic nerve evaluation and detection of extraocular extension of panieloblastoma. 6. Systemic assessment include physical examination in MRI, scans of the orbit and skull as a minimum in high-risk cases. If these indicate the presence of metastatic disease, then bone scan, bone marrow aspiration, and lumbar puncture are also performed. 7. Genetic studies require fresh tumor tissue from the inoculated eye and a blood sample for DNA analysis. Blood samples from the patient's relative and a sperm sample from a father may also be useful. Treatment of retinoblastoma is according to the size of the tumor, diameter, and thickness. We may use photocoagulation, cryotherapy, brachytherapy, chemotherapy, radiotherapy, and enucleation. The second intraocular tumor we will discuss in our lecture is malignant melanoma. Choroidal melanoma has an overall incidence of 5 to 7.5 per million per year in Western Hemisphere countries, with no significant gender differences. It is the most common primary intraocular malignancy in adults and accounts for 80% of all uveal melanomas. Pattern of the tumor separate is as follows: penetration of pulp membrane and the RPE with herniation into the subretinal space, often with the development of color stud shape, or invasion of scleral channels for blood vessels and nerves resulting in orbital separate, also invasion of the vortex vein, or sometimes metastatic hematogenous separate to the liver and occasionally to the lung, bone, skin, and brain. Optic nerve invasion is very rare, but may occur in eyes with large peripapillary melanoma. Presentation of malignant melanoma. Presentation peaks at around the age of 60 years and occur in one of the following ways. Either an asymptomatic tumor, usually in the periphery, is detected by chance or routine fundus examination performed for other reasons, or a symptomatic tumor causes decreased visual acuity, blurring of vision, metamorphopsia, visual field loss, floaters, or photopsia. Signs that we can see during examination. A salutary elevated subretinal dome-shaped mass, which may be pigmented or less commonly amelanotic. The former are usually gray or brown. About 60% of the tumors are located within 3 mm of the optic disc or fovea. Clumps of orange pigment are frequently seen in the RPE overlying the tumor. If the tumor breaks through the pulp membrane, it acquires color stud appearance, with visible blood vessels if the tumor is amelanotic. A diffuse tumor is rare and is characterized by an extensive flat or slightly raised morphology, with a gray or brown irregular discoloration. Exudative retinal detachment, initially confined to the surface of the tumor, and would later shift inferiorly and become fullous. Unlike rhegmatogenous retinal detachment, the subretinal fluid shifts with ocular movement, anti-gravity, called shifting fluid. Other signs include choroidal folds, intraocular inflammation, hemorrhage, proboscis iridis, secondary glaucoma, and cataracts. Investigations. Although binocular indirect ophthalmoscopy combined with indirect slit-lamp microscopy is sufficient for the diagnosis, in the vast majority of cases, the following may be useful. Fluorescein angiography is of limited diagnostic value because there is no pathognomonic pattern. The most common findings are intrinsic tumor dual circulation. Ultrasound is useful in detecting tumors when the media are opaque and to show extraocular extension. It is also useful in measuring tumor dimensions. The characteristic findings are internal homogeneity, choroidal excavation, and orbital shadowing. A color stud configuration is almost pathognomonic. Indocyanine green usually show hypofluorescence. MRI enhancement with gadolinium improve image quality, demonstrating optic nerve and orbital invasion, and facilitating differentiation from other tumors. Color-coded Doppler imaging also helpful. Biopsy is useful when the diagnosis cannot be established by less invasive methods. Systemic investigation is very important. Systemic investigation is aimed at the following. First, excluding a metastasis to the choroid, most frequently from the lung, in both sexes and from the breast in women. Occasionally the primary site is the kidney or the gastrointestinal tract. So first we want to exclude that the tumor is metastasis from other sites. Second point, detect the possible metastatic separate from the choroid because of the large tumor size, and if there is clinical suspicion of metastatic separate, hepatic involvement can be detected by ultrasonography and elevated lactate dehydrogenase, gamma-glutamyl transpeptidase, and alkaline phosphatase level. Chest radiography rarely shows lung secondaries in the absence of liver metastasis. Only about 1 to 2% of patients have detectable metastasis at the time of presentation. Principles of treatment. Treatment is performed to avoid the development of painful and unsightly eye, preferably conserving as much useful vision as possible. Since it is not known when metastasis occurs, it is uncertain as to whether or not ocular treatment influences survival. Theoretically, the smaller the tumor, the greater the opportunity for preventing metastasis, and therefore the more urgent is the need for treatment. Management should be tailored to the individual patient, taking the following factors into consideration: size, location, and extent of the tumor together with effects on vision, state of the fellow eye, the general health and age of the patient wishes and fears. Treatment may not be required in the following cases: if the tumor is slow growing and presents in the only seeing eye of a very elderly or chronically ill patient. If it is not possible to determine clinically whether the tumor is a small melanoma or a large nevus, in this case the lesion is observed and treatment is administered only if growth is documented by sequential ultrasonography or photography. Treatment options are brachytherapy, radiotherapy, transpupillary thermotherapy, and enucleation.